So let me go ahead and start. And I want to start out with a history of women in cardiology. If we go back to the early ages, women were involved actually with healing the heart in many ways. I suspect they were doing this with natural herbs and remedies, maybe even foxglove. But really, women did not come on the forefront in cardiology sort of until the 1960 reign. And it was still very unusual to see women in cardiology in the private practice sector or even in academia. You'll notice the American Heart Association, ACC, were formed far earlier. The pictures here you see are women that were in positions of leadership in the 1960s, 1970s, and then in 1987, the Mayo Clinic hired its first female cardiologist. Now, at about the same time I was graduating from medical school, I had never met a woman cardiologist. Yet I really wanted to go into cardiology. And God knows why, but when I told this to one of my mentors, she said, why would you want to do that? Why don't you do something less technical, more human-like? I didn't know what that meant, so I went on and I did residency, and I'll tell you a little bit about my story. But I want to just say it took until the 1990s until sections of the ACC and AHA actually formed committees on women in cardiology to help our fellows and trainees actually be mentored and then attract younger trainees to go into the field of cardiology. So this is my story. When I was internal medicine residency, I got interested in cardiology because it was a very exciting time. Thrombolytic therapy had come on the forefront. And we were actually able to see actual results in the emergency room administering thrombolytics, and then later, of course, primary PCI. And so I was hooked right then and there. And a group of my colleagues in internal medicine and we used to do after-hour journal clubs. Really. We used to meet after hours and discuss all the thrombolytic trials, the stents that were coming on the forefront, primary PCI. So that was it. I was applying. It didn't matter that I hadn't met a female mentor at that point. So I interviewed at 6 programs, but I only ranked 2 programs because my interviews went so badly at the other 4. And they ranged from one person, and these were all people interviewing me in positions of leadership within their cardiology programs. One spent the whole interview just asking me about my hobbies, nothing about cardiology. He wanted to know what he could do to improve his picture quality, because I have an interest in photography. Another interviewer asked me if I was slumming. Why was I at his institute? Because evidently he didn't think much of his institute. And another time, I was in a room. I was the only female applicant there, and the chief of cardiology came in and handed me a stethoscope. Only me. Took me to the CCU and had me do rounds with him. Some of my colleagues in the room, the men, were quite jealous, actually, because they didn't understand why I was getting special attention. So in the end, I ranked 2 programs, and then cardiology fellowship began. But some things are not under control all the time. So on July 1st, cardiology fellowship began, but I walked in very pregnant and had my first baby on July 3rd. And the response from the chief of cardiology in front of everyone was, when are we going to be a full member of the team? So I had to assure him that I had already arranged with the fellowship director to do my research up front. So fellowship went on, and I began to have my doubts because the women cardiologists that I finally met in my program were not treated very well. And the female fellows were subjected to such things as the male fellows asking us to turn their heads so they could change in the workroom, et cetera. So it was a rough time, and I actually considered jumping ship and going to hem-onc. But I stuck it out and ended up completing the program in 1995, and by that time I was very pregnant again. and it was time to graduate. And I remember going to one of my mentors at the time, telling her I was going to leave a couple weeks early because I had saved up my vacation and I needed to, go and move for my job. And she just looked at me, she goes, well, I don't think that's allowed. You can't leave fellowship early, even if you have vacation. So it was quite a tumultuous time. So second child was born. And then I went on to begin my first job in a medical school on faculty, and I was the only woman at the time. But I was glad that I was finally out of fellowship. But then I met newer problems. Even after being promised, if I got a grant, that I would have equipment to work with, et cetera, roadblocks began to be thrown up, and I had to fight tooth and nail. So times were tough, but I persevered and came up here to UT Southwestern about a decade or more ago now and took my second job on faculty. So a little bit about my story. So I would like to think that in the 2+ decades since my fellowship that things have changed. I've had the privilege to train many female fellows, mentor many residents, medical students that want to do cardiology. So about a year ago, when I was preparing for last year's talk, my husband threw over his alumni magazine and said, you need to read this. And it was about some happenings that were going on at Yale at the time. And it was in the cardiology department. And I was in total shock because sometimes things don't change all the time. And so Yale responded, to this. And I'll tell you, this person was a position in high leadership within cardiology. By asking him to step down from that position, but actually did not ask him to leave the university altogether and just put him in another position of leadership. And then to satisfy people, they did put together a task force for gender equity. So it's just showing you, even in this day and age, we have to stay on our toes, I think, as women and be on the lookout for this. So where are we today with our trainees? Well, despite the fact that 50% of our medical students and internal medicine residents are women, if you look at general cardiology, fellows in training, congestive heart failure, EP, interventional, you can see that our numbers remain very low compared to the other subspecialties in medicine. So we're still not able to attract women at the same rate that we're attracting men. So how has this changed over time? Well, when I was in fellowship, maybe 13% of cardiology fellows were women at that time. It has risen. We're now, with the latest data, at about 22%. But this doesn't even, if you look at the surgical residencies, they've been able to do a better job of attracting women than even cardiology. So we still have a lot of work to do. And this translates to what happens in the workforce. If you can see, the purple bar is women in general cardiology, and the blue bar being men. So less than 12% of all general cardiologists are women. And if you look at the interventional sectors, EP and interventional cardiology, less than 10% of women. Pediatric cardiologists, on the other hand, actually are a much higher percentage at about 30%. So what are the barriers? Because this is our job. Our job is cardiologists, fellows, because the fellows need to mentor as well. What barriers do we need to overcome to attract the best people to come into our subspecialty? I like to think of this in 3 different ways: work-related factors and personal factors. We'll start with work-related. So the climate that you're working in, sort of any discrimination that goes on, or the macho image, that's something that needs to go to make people feel comfortable to train. It's difficult enough to train without dealing with that. Unequal salary compensation, I'm going to touch upon this because this still exists. And the lack of mentors and role models, in female role models. We have, with only 20% or so in our numbers and 13%, across the board right now as far as general cardiologists, there just aren't enough people to mentor as far as our fellows coming in. So if we look at personal factors, you're considered advanced maternal age when you're over 35, which is kind of scary, but it's the truth. And there was one article that said there is an achievement syndrome in a lot of women that go into medicine, and that they're so focused on their studies and their training in their early part of the years, that they don't make time to sort of meet a partner, have a family, et cetera. So all of a sudden they get to the end of internal medicine training, they're 30 years old, and are they going to invest now 4 or 5 more years in cardiology, or are they going to try to find someone to be with for the rest of their life? And of course there's educational debt. With a lot of our trainees coming out much in debt, invest in 4 or 5 more years when they could be out earning a better salary is certainly a factor. And then the ones that kind of overlap, radiation exposure. How much radiation exposure do I want over a lifetime versus during my childbearing years? And there's the duration of the rigor and training, work pattern. And we also find this phenomenon that the Gen Xers may be taking something called the E-road, which is going into subspecialties that perhaps don't entail as much call and unpredictability. And you can see emergency medicine, radiology, ophthalmology, et cetera, et cetera. So let's tackle radiation exposure, because it's estimated that more than 40% of our trainees actually alter their career plans just to reduce radiation exposure. So the mean effective dose for an expert operator in the cath lab or EP lab is said to be on the average of 4 millisieverts per year. So let's contrast that with what is the probability of having a child with a congenital malformation, or that child having childhood cancer from radiation exposure. So 4% of the general population will have a child that will have either a malformation or go on to develop childhood cancer. And then the estimation of radiation exposure at 1 millisievert per year, you can see there's very minimal increase, okay, over that baseline general population. And even if your radiation exposure is more than 10 millisieverts per year, again, a rather small increase. So the current recommendations from the International Commission of Radiology Protection, and there's a national council, that you should receive no more than 1 millisievert per year. The National Council says, 1 millisievert for the entire gestation, and that contrasts a little bit with the National Council of Radiation Exposure that says less than 5 millisieverts for the gestation. In reality, the majority of women don't perform fluoroscopy while pregnant. The early weeks of pregnancy, of course, are the most highest risk time. And the later weeks, just practical considerations, being able to reach the cath table and be comfortable. It's recommended, of course, that you meet with a radiation safety officer and that you decrease your procedures by about 50%. And one just important aspect for our cardiology fellows or anybody that does nuclear, it's recommended actually during pregnancy that you don't inject and that you should, of course, wear your badge at all times then. Okay, so understanding career decisions. Where are women going in cardiology? More women tend to be attracted towards academia over private practice. Less women are married than male cardiologists, and less women have children than our male counterparts. More women within their career have reported discrimination, both due to parenting roles and also sexual discrimination. As far as compensation, this was a recent publication. Actually, it's not been published yet. It's pre-publication data from Jack that looked at the compensation of both male and female cardiologists related to their work activities. So again, they found there were more women in general non-invasive cardiology practices, and definitely more men within EP and interventional. Both men and women tended to work full-time over part-time, the women a little less. And as you can see, the work RVUs were a bit lower for women than men. So how did that translate to their salaries? So this study controlled, importantly, for the RVUs, for the amount worked, and came up that women, should have received a mean salary that was at least $31,000 higher based on their workload. So basically, still, their salaries were lower. And this was mostly in US practices. I think they were mostly private practice. And there was an independent association between gender and salary that couldn't be explained by their measures of their personal job or practice characteristics. And similarly, in 2015, Medscape put out a compensation report, and they broke it down to women that were self-employed versus those that were employed. And you can see the biggest discrepancy, and this was not controlled for work RVUs, et cetera, were those that were employed. So maybe academia versus a self-employed or private practice, it looked pretty equal, actually. So if we look at, in academia, what goes on as far as women in leadership roles, and this is not just cardiology, this is all faculty at medical schools, you can see that by the time you get to the associate and the full professor level, something happens to the woman. I'm just trying to find the pointer, but that's okay. Something happens, women either decide to drop out of academia, or perhaps they're stagnant within the lower ranks than men. And so, interestingly, this same Medscape study from 2015 also polled cardiologists on their satisfaction of their salary. More men than women actually were satisfied with their current salary compensation. So I think, it's pretty obvious why we need women cardiologists. Female patients, female physicians communicate differently with their patients. We have real-life experience. It may be patient preference. And we really want to attract the best and the brightest candidates, including women, to the field. So if we look at solutions, what can we do to combat these barriers? Some of them are worksite related and pretty obvious. We need to try to provide on-site daycare and lactation support. Importantly, we need to delegate. And I think as women, we tend to multitask very well and perhaps not delegate as well. And there was a recent study looking at hours spent on household duties to K1 awardees, men versus women. And on average, the woman with the K awards actually worked 8.5 hours on household duties more than their male counterparts. And just think of all that time that could be spent, doing productivity in the workplace. So we have to have, I believe, zero tolerance on discriminatory practices. The compensation for your salary should be fair and transparent. And I think it's our job to promote an accurate image of career pathways. Not every cardiologist is on call 24/7. There are part-time or three-quarter-time positions available. We need to take a strong role in expanding mentorship and leadership opportunities. There are workshops at most academic places that people are training for promotion and tenure of junior faculty, and you should go to those workshops. And I think as we promote more women to positions of leadership, that network of mentors will grow. The other thing we need to think about is whether we have alternative career pathways, whether we can shorten training in any way. Job sharing is another possibility. And importantly, during childbearing years, maybe if you're an interventional cardiologist, you're going to spend, and you don't want to be in the cath lab as much, spend some time doing general cardiology, teach, do research, and consider practices, should consider temporary replacements during that time. So basically, my advice is to do your homework well and utilize the resources you have. Make sure you're training and working in a supportive, family-friendly environment, and I can't stress this enough. You really need to check out the place you want to work. You should identify mentors at all levels of training, and they don't always have to be female, okay? They just have to be supportive, but it helps if they're also female. You should use your connections, and you should constantly ask for feedback. When you're negotiating, you should negotiate. Women do not do this well at all. Salaries are typically available online. You should put everything in writing, and you should always ask for more. Think about non-traditional career tracks and get involved on a local and national level. And like I mentioned, I think our fellows in training need to begin mentoring. So as far as what's available out there, fellows can join the WIC section of the ACC for free. They have workshops at National ACC and other times. There's a virtual mentoring program you can be involved in and get a mentor or be a mentor. And there's a visiting professor programs, recommended books on the website. And the AHA has also a Women in Cardiology committee, and they give out 24 awards, early career awards, and usually fellows can go to the meeting for free and participate in mentoring programs and sessions. So I just want to close with our cardiology faculty, and we're proud to say that at UT Southwestern we have 35% of our faculty members are women, and this was a private communication from our chief, Joe Hill. And right now, we'd like to increase the number of women in our cardiology program. Right now, about 20% of our general cardiology fellow graduates have been women. I just heard from Anand Prasad that right now he has 50% of his fellows are women down in San Antonio. So with that, I'm going to just end and thank you for your attention.